Brought to you by Dr. Joe Ordia. Frequently asked questions about neurosurgery and pain management. Questions 21 to 25. I start with a disclaimer. The opinions expressed here are for general information and based on my own professional experience. They are not intended to replace the advice of your healthcare provider on your particular condition.
Question number 21. I have been working in construction for more than 20 years. I get pain in my back off and on. I heard that the spine is similar to the frame of a house. I don't get it. Could you explain it to me?
Answer. The spine consists of a number of bony structures called vertebrae, which house and protect the spinal cord and nerve roots. When viewed in a transverse plane, the strong bony foundation in front is the cylindrical vertebral body. A pillar, called the pedicle, extends backwards on either side and connects to the triangular roof, or lamina. The chimney represents the spinous process. A bony wing called the transverse process projects from each side of the pedicle and provides attachment for muscles which play a role in maintaining posture. Between the pedicle and lamina, a pair of processes called the facets extend upwards and downwards. The 33 vertebrae form a chain, and the vertebral bodies are cushioned by discs which have a central gel that acts as a shock absorber and an outer ring of strong fibrous tissue. The synovial joints of the facets allow for various motions. The ligamentum flavum, yellow ligament, is the thick ceiling which connects adjacent laminae and also attaches to the facet joints. The spine has three primary functions. 1. Protection of the spinal cord and nerve roots from the base of the skull to the tailbone. 2. Maintenance of posture. 3. Facilitate movements of the head, neck, back, and hips. Wear and tear, arthritis, or injury to any of the structures may cause back pain.
Question number 22. I get pain, cramping and numbness in my legs when I walk. I have to lean on a cart when I go to the supermarket. The PA, physician's assistant, said that I have narrowing of the spine, and that when I lean on the cart it opens it up and that's why I get better. How does the bone open up?
Answer. In the overview of the anatomy, I explained that the spine houses and protects the spinal cord and nerve roots. Narrowing of the spine is referred to as spinal stenosis. It is often caused by wear and tear, resulting in arthritis, which involves most of the structures of the spine. The outer ring of the disc degenerates and bulges out. The central gel becomes dry, shrinks, and is less effective as a shock absorber. There is loss of bone mass and development of bone spurs in the vertebral bodies, and enlargement of the facet joints. The ligamentum flavum loses elastin fibers and its elasticity, and there is thickening and buckling of the collagen component into the spinal canal. The result is spinal stenosis, with compression of the spinal cord and nerve roots. When you bend or lean forward, the ligamentum flavum unfolds, flattens out, and there is less compression. That is what is responsible for the temporary relief of your symptoms, which are collectively known as neurogenic claudication.
Question number 23. My grandmother lives in Arizona. Her neurosurgeon said that she has spinal stenosis in her back and recommended laminectomy under general anesthesia. Her primary care would not clear her for anesthesia because she has heart and breathing problems. She can hardly walk and she really wants something to be done. Epidural steroid injections helped her for a couple of years but not anymore. Are there other options?
Answer. Decompressive lumbar laminectomy involves removal of the lamina, ligamentum flavum, and thickened facet joint to take pressure off from the nerves. A fusion may be done as well if the spine is noted to be unstable from the primary arthritis or expected to be so after an extensive decompression. Minimally invasive options that often do not require general anesthesia may be considered, especially in cases where thickening of the ligamentum flavum is the predominant cause of the stenosis. 1. Interspinous spacer procedure. A device is implanted between adjacent spinous processes to provide some flexion and limit extension. This results in unfolding and flattening of the ligamentum flavum and relief of pressure on the nerves. 2. Minimally invasive lumbar decompression, mild. A less than 1 centimeter long incision is made, and with fluoroscopic guidance, a small tubular port is directed to the ligamentum flavum between the laminae. Special instruments are passed through the port to remove pieces of the ligament. Injection of contrast material in the spine during the procedure will give a good idea as to how well the canal has been decompressed.
Question number 24. Back problem is common in my family, and many have had lumbar laminectomy. My nephew has had back pain for many years. He eats healthy, there is no ounce of fat in his body, he attends PT and goes to the gym at least 3 times a week. His low back pain has been getting worse recently, and his spine surgeon said that he has discogenic pain, not sciatica. We are confused. What is discogenic pain?
Answer. In one of our earlier discussions, I likened the vertebrae to a chain which provides protection to the spinal cord and nerve roots, supports posture, and allows for body movements. The discs are the cushions and shock absorbers between the bony vertebrae. They are innervated by sinew-vertebral nerves, which are mostly present in the outer fibrous ring called the annulus. These nerves are different from the nerve roots that supply the muscles and skin of the extremities. Annular disruption and disc degeneration can occur from wear and tear, related to repetitive movement of the back. Irritation of the sinew-vertebral nerves results in the type of back pain known as discogenic pain. Unlike sciatica, which arises from pinching of the nerve roots, discogenic pain is mostly confined to the back, but can be referred to the thigh or leg. The initial treatment often includes measures such as activity modification, home exercise program, PT, anti-inflammatory medication, chiropractic, and acupuncture.
Question number 25. I told you about my nephew, and you provided an explanation of discogenic pain, the diagnosis which his spine surgeon made. He went on a brief visit to Newfoundland in Canada, and the cold weather wasn't kind to his back. He has spent the better part of the past 6 months doing all those things you mentioned, PT, chiropractic, injections, you name it. He had a discogram last week, and his surgeon wants to remove the disc and replace it with some type of an artificial disc device. The surgery will be done from the front, and a vascular surgeon will be assisting him. None of us has ever heard about artificial disc. Can you explain anything about the surgery?
Answer. If discogenic back pain persists despite standard treatments and significantly impacts quality of life, disrupting everyday activities, it may require closer examination. Your interventional pain physician or spine surgeon may perform a minimally invasive provocation test called discography to pinpoint the specific disc that is responsible for the pain. Following confirmation, more advanced treatment options can be considered. One minimally invasive approach is radiofrequency ablation of the sinew-vertebral nerves. Surgical options include discectomy and spinal fusion. One drawback is that more motion occurs at the vertebral levels adjacent to the fusion, making them vulnerable to developing progressive arthritic changes. For some patients, total disc replacement with an FDA-approved prosthetic disc may be a better choice over a fusion. The surgery requires an exposure through the abdomen and navigation between several blood vessels. The services of a vascular surgeon who is more familiar with that environment are crucial for this aspect of the operation. With disc replacement, range of motion is preserved and the stress on adjacent levels is minimized.